好的，好的，谢谢。因为时间关系，这个佳宁教授还有别的会议的任务，那么等这个佳宁教授讲完，我们再。
Okay, so Jianing has other meetings later, so we will invite Professor Yue Jianing to present first. Apologies. Now I will go back to this case sharing. It's FemPop aneurysm plus BTK lesion. So 69-year-old male. This is an old case a few years ago, but I think it's very interesting. And also a couple of months ago, he did the follow-up visit. That's why I took out this case. It's Rutherford 4. When he came to the hospital, there's a resting pain. And also, there's a multiple CVD, including coronary disease. So when he came, it's a very typical ISO, and also it's IC, it's intermittent claudication, and it's not at acute phase. And we can see ABI 0.26. That's very typical. So we did the CT. And we looked at the cross-section. We found that, there's the FemPop aneurysm, not very big. And there's thrombosis. And our judgment is that there's no big aneurysm and with the thrombus dropping because it's not acute phase. And also, considering the coronary disease history, we think there's ISO and also the distal end not so good. That's why there's a secondary aneurysm. So it's a very complicated case. And for this case, we did angiography. And we found that SFA, there's some residual thrombosis, and also we find the arteriosclerosis stenosis and the runoff very poor. So TP trunk and the trifurcation, we found there's the atherosclerotic stenosis, and we can see the lesion here. And we think that the runoff very poor, and the patient received 3 PCI, and also there's a stent in the heart. So we decided to do endo. And for endo, of course, this is an old case, and we didn't have the debulking device. However, if the patient is the patient today, I still choose thrombolysis because I don't really know the BTK condition, so it's really difficult to choose the debulking device. And also the aneurysm, we can see the thrombosis burden very heavy, and also there's an uneven lumen. So I think thrombolysis is the reasonable way to go. And you can see it's a thrombosis and passing very easy. However, TP trunk, we use a V18 wire, and then we reconfirm the runoff. We use thrombolysis. We use the thrombolysis catheter, and we normally use urokinase for thrombolysis. On the next day, we did the angiography. So very good results, and matching our judgment. It's a secondary thrombosis, and it's a fresh thrombosis. And also you can see trifurcation, a lot of plaque and residual thrombus, and FemPop aneurysm, and there we should choose cover the stent, and also there's residual thrombus. How about the distal anchoring? Maybe anchoring at the P3 or to the TP trunk, and we know that the artery is smaller. And for Viabond, it's not really good for the anchoring because there's the risk of the margin, and we are very confident with the covered stent because the evidence shows that for FEMPOP aneurysm, covered stents have very good results. It is comparable to surgery. So for distal runoff, we decided, considering the distal runoff, we decided to use DS. We use science and it's coronary and product, but there is a BTK evidence. And because of the BTK evidence in the US, I think science BTK, this stent in the US, there's an indication for BTK. So BTK trifurcation, we use DS to do the revascularization. You can see very good angiogram, very good flow. However, at the trifurcation, there's a calcification and also there's thrombus. So we entered into posterior tibial and we use Zeiss 4 millimeter to cross the posterior tibial and also the perennial ostium. And we place in the DES. It's a balloon expandable DES, and we place in Y-bond, and in order to avoid the restenosis of the edge, the distal end of the Y-bond will be anchored at the DES. So altogether 3. So 15 centimeter and 6 and 7 to the upper part of SFA, and we think that this is something we can do. This is the best strategy to avoid restenosis. So Y-bond anchored in the DES. However, after angiography, we found that at the ostium of the stent, at the perennial artery, we are not very happy. So it's a covered stent. We put in the covered stent. We want to maximize the runoff flow. So we decided to do T-shape, and we know for T-shape there are many strategies. We already put in the first stent, and eventually we chose Culotte. We go through the fenestration, and then because it's balloon expandable, and then we put in the DS. That's how we do. So we go through the fenestration, and then we put in the Boston Scientific DS, and we completed the Culotte stenting, the T shape at TP bifurcation.
This patient actually be able to have a very good treatment. So you can see this is after the Culotte stenting, and the performance is much better, especially at the tree furcation, and actually the vascular restoration has been greatly done. And right after the surgery, the ABI is being recovered to more than 1, where it's very interesting for us to see this patient. It's a senior professor from Shanghai Fine Art Academy. He come back for follow-up a lot. I got a lot of evidence for the follow-up. This is a second visit for the follow-up. At 6 months after the treatment, we did the CT imaging, and you can see that for this patient at the trifurcation, the patient still show very good result. The patient come back to me for 7-year follow-up. At the very beginning, we used the bifurcation treatment, but in 2019, and the patient started to have the thrombolysis and also urgent onset. We did the thrombolysis for the patient and without placing any stenting in, and the patient has been followed for 7 years. And later we have the anticoagulate treatment as medicines being provided to the patient. The patient visited me in July of this year, and its ABI still be greatly maintained. You can see these are the follow-up CDA. So till now, the patient has been followed for 7 years. Due to pandemic reason, in 2020, 2021, he didn't come back, but in July of this year, he come back again for the last visit. That's the case presentation. So Professor Bao And Dr. Walker would like to hear your comment. Thank you. Thanks for Professor Jiang. Very good case. And this is actually a challenge patient using the stent graft and then the DES of restoring the performance. It is very good to see the patient have a 7-year follow-up with complete evidence being built. So Professor Dr. Walker would like to hear your comment. Welcome.
Yeah, excellent case, wonderful technique. And before I heard many say how you envy some of the tools that we have. Well, I used to have urokinase, and we don't have this available in the U.S. now. I thought it was a far superior thrombolytic in peripheral cases to TPA or TNK. We found that we had better clot lysis, and we found less complications as we used it, which is crucial here, but that's really a beautiful case. You established flow, you excluded the vessel, you've managed it, really exemplary case. And I think this patient owes you a lot because you've saved his leg. This is very difficult treatment and exceptional outcome.
Thank you.
这个沃克教授给了佳宁
Yes, indeed. Very good recognition and praise from Dr. Walker to Dr. Zhang. Yes, indeed, you can see for such a patient, the critical part is the restoration of flow out. Especially, you can see for this patient, you use a lot of tools, stenting, and also the size prime stent. In the past, we also have the indication of use it, but later it's being removed. So let's welcome Professor Yan to comment on this case. Thank you. Thanks for Professor Bao. This is a very good case. Yes, indeed. Just like Professor Bao mentioned, we commonly see such a kind of patient, but a big reason is that the distal flow out channel, and more importantly, and you know that for the distal flow out channel, sometimes we need to use a larger Y bond to place in the distal site, and then it's going to have a raised diagnosis very easily. But for Professor Jiang, and you use the drug washout stent, which can help to prohibit the proliferation of the interior epithelia. I have a question to you, Professor Jiang, and you place a size. I think the largest diameter is a 4 millimeter, and you still placed a 6 millimeter Y bond. How can you do that? And why should you place a size first? Why should you place Y bond first? And what's your consideration? Why should you also have a DS inside? Yes, indeed. You'll see for this patient, actually, it has a very severe situation. So in the proximal site, you probably gonna you use the proximal site in the femoral artery, and the diameter would be 7 millimeter, where I don't want to have a very strong shrink of the Y bond. So, but at that time, for the side one, it's only going to be 4 millimeter for the largest one. If we place Y bond first, then the size going to have some stability issue because its diameter is only 4 millimeter, and also going to generate some it's also not going to have the anti-raise diagnosis, because you know that Y bond once being placed, once there's any dilation it's been happened for this patient, the size going to be not stable if you place one Y bond in first. So I use place size first and place a Y bond into the drug-coated stent. And in that way, I believe it's going to help to avoid the race diagnosis for this patient. Okay, great. Very good consideration. After you place Y bond to the distal section, did you actually do some post dilation? No, I didn't. I didn't do that. I didn't do any post dilation at all. Okay, great. Okay, Professor Ye. Good, very good. A very nice case done by Dr. Zhang. This case being performed many years ago, even if till today, after 7 years, it has a very classical example. You mentioned if we're going to encounter the same patient, you're probably still going to choose thrombolysis. But now we have the debulking device and option available. So how you're going to use the drug dosage? And I was using the same drug as what you meant. And what would be your dosage consideration? And Dr. Walker mentioned in the US, you actually don't use uricase, and they use RTKA. We have RTKA, but if you take a look at the indication in China, it's not allowed for such a case. Once there's any lawsuit involved, you're going to be the loser. Sometimes I use RTKA. So if the patient is going to do thrombolysis, are you going to use uricase or other agent? What would be the dosage of the uricase? Thank you. For uricase, generally speaking, it's around within 24 hours, it's going to be around 1 million units. It truly depends on the renal functions, the age of the patient to adjust the dosage. But generally speaking, we have the intermediate treatment because within the shells, we're going to maintain with the heparin to make sure that after 6, and we use uricase, 1 injection every 6 hours, and altogether 1 million units for each day. And when we have the 4 hours interval between each injection of the uricase, we use as a heparin in treating the patient. That's what we have. We find out the result is okay. For some patients, they find out that thrombosis is hard to be taken care of, and but the total volume or the dosage per each day would be 1 million units of the urine case. RTPA, I didn't use it before because of the indication within China label. Once there's any hemophage, if I use it in off-label approach, I'm going to be brought to the court. So now I still use the urine case. And now we have more debulking solution. I seldom use urine case for thrombolysis. For such a complicated cases, thrombolysis actually help us to unveil the lesion with a very clear surgical field. Thank you. This is a case with very, very nice tactics. I'm lucky to see it here, and I also see the 7-year follow-up. What a good case. We're talking about thrombolysis. I'm not 100% agree with you, Dr. Jiang. If it is a patient, you know that with the disease, and especially for such artery UIA patient, and it really takes time for them to have the lesion. Ultimately, you need the Y-bond and the stent graft in treating the patient. But more importantly, to shorten the lesion, there's a possibility for you to shorten the lesion. Well, for some aged patient, especially the patient, such lesion going to happen for the people around 70 to 80 years old. If you use a thrombolysis, you won't be able to see very good response from the patient, and also going to generate the completion risks. It truly depends on the patient, the medical history, and the imaging screening to see whether the thrombosis is a new one or the old one. Well, talking about for such a thrombosis patient, I don't use thrombolysis a lot. Considering the completion risks, I just use EVA or to do the debulking to recanalize the vessel. Thank you. Very nice case. Yes, I think you guys are not. In order to improve the outflow channel, we use thrombolysis. Professor Nair, would you mind to give a few comments? And also Professor Finn, Professor Nair, would you mind to say a few words on this case?
So I watched that case and I thought of many issues. It brings me back to some of the cases that I've seen. Those are some of the most challenging cases of limb salvage that you can have. Why? Thrombosis of the vessel is probably the most dangerous and most complex vascular disease processes to deal with because of distal emboli, and the risk of thrombolysis with intracranial bleeding and so forth. However, that was a phenomenal case of limb salvage. And I have to say that in my assessment, looking at that case, the outflow was quite poor initially. You could see the outflow vessels. So I think the choice of thrombolytics was correct, in my opinion. That's exactly what I would have done. And also looking at the outflow vessels post thrombolysis, the choice of culotte as an interventional cardiologist, I don't typically do bifurcation stenting in the tibial vessels, but in this scenario, I think it was the right choice. I think keeping those two outflow vessels was vitally important and crucial to maintain patency, because without good outflow, that Viabon stent graft would go down. So, you know, I look at that, and I'm also thinking in the future, whether or not drug-coated balloons for the tibial vessels in those locations would be options for us down the road. But I have to congratulate you, because that was a phenomenal case.
Thank you.
Two quick comments is again, doing the culotte really caught my eye, given that it's so labor intensive, with 13 balloon inflations or more to complete the steps. I really applaud you for taking the time to do that. Many times I'll try, rather than proceeding with that, I'll try just a simple kissing balloon and see how our results come out and see if I can avoid it, or kiss and then plant one of the limbs of the culotte and see if it looks adequate, similar to a coronary technique of provisional for the other vessel. And a lot of times I can get away without having to perform the full culotte. The other comment I would make was on your choice of anticoagulation therapy. I fully agree with that, especially after the patient had the re-occlusion down the road. I think being very aggressive with your rivaroxaban choice was an excellent decision. I think the use of the rivaroxaban 2.5 dose twice a day shows less acute limb ischemia in their major trial in peripheral arterial disease to help prevent these kind of restenosis, and I'm using it quite often. I'm not sure if it's available in China or not, but we're using it very frequently here in the United States. And this would be one of the cases I would think about it in. I might even think about full anticoagulation for a long period of time, and then downgrade to that once I've established that things are more stable.
好的，感谢 Finn 教授的这个
Thank you
点
very
评。
much. Thanks for the wonderful comment from Professor Finn. We have already overrun for this session. So coming up.